Thank you so much. All right, next we have the opportunity to hear from the wonderful Dr. Naomi Bardach about what we've learned in the last year about school reopening and safety. And then we're going to switch up the order so that we have a chance to hear from Dr. Gandhi about vaccines and variants.
Okay, thank you. And I'll agree that stress looks like many things. And my child at home, sometimes he gets really irritable when he gets really stressed. So that's the other thing sometimes that comes up for folks. Next slide, please. The talk that I'm going to be giving, I just think it's helpful, and thank you so much, Ms. Trotter, for such a wonderful sort of framing of this conversation. Part of what I'm talking about is actually sort of the scientific evidence, as much as we know about, how to create safe schools, or what does a safe school environment look like. And I think it's helpful. I really appreciated the call out for transparency and what are the different hats we're wearing. I wear a hat of looking for the best information possible. So sometimes people say, oh, Dr. Bardach, she just, believes in XYZ. She only is looking for information about school reopening being good. Or sometimes people are only looking for school reopening being bad. And the commitment I have made in general to this whole endeavor, because it's so important to get it right, is that I always look for the very best information we can get. And so that's what I'm trying to share with you today, to help you guys begin to understand the best scientific information we have to inform how to do a safe school. So the pathway forward is this. What is this? Big, wide open road, but there's two guardrails. On one side, the possibility in COVID is to open up schools too much, just everything open, no safety mitigation at all, no safety guards, nothing. And we've seen that that can lead to outbreaks. Early in the pandemic, we saw that there are a lot of outbreaks. That meant no masking, kids all packed in, no ventilation, no physical distancing. That's one side. We need to protect against that. That's not good for our teachers, for our students, for our families. On the other side is kids staying in school in distance learning and not seeing even a single day of in-person learning for too long. And we know that that has terrible effects for our students, for our mental health as a community, that it's really hard educationally, and that it drives inequities deeper if we're not paying very close attention to being able to help support those kids as they're managing distance learning. And I'll echo Ms. Trotter's comment that the work that teachers have done has been extraordinary. And so now today is the first day to also help support extraordinary work in a way that is also psychologically and mentally sort of feeling like you're in a safe space and that the kids are in a safe space. Next slide, please. And the pathway forward is not this, crashing off the road. So how do we get there? Next slide. So we know more now than we did in March 2020. Early in the pandemic, we all thought every kid is going to spread this virus everywhere. We got to shut down the schools. Next slide. And what do we know? Here's kind of the summary of what we know. Children get COVID-19 less often and are less ill than adults. And sorry, I like to give the take-home points first so that all the data sort of sits a little bit more easily in the brain, which you probably all know as educators is sometimes a good way to do it. So COVID-19 less often and are less ill than adults. Children do not seem to be major sources of transmission to each other or to adults. Transmission in elementary schools, however, is different from high schools, especially if there's no masks involved. Adult to adult transmission is the most likely in the school setting, but also therefore where we have the most control. Community prevalence is going to affect school-based cases, how many cases are in the school, but not necessarily in school transmission, which is what is the really, really key piece. We know outside of school, inside of school, cases go up and down. But the in-school transmission, where one case goes to infect somebody else, is what we really need to make sure we're putting those safety layers in place to stop. What are those safety layers? Masking, physical distancing, stable groups, ventilation, hand hygiene, symptom screening and screening for contacts, and surveillance testing. You'll hear these themes throughout the talk. How do we do those things? And what's the evidence behind that? Dr. Frank is going to tell, or Ms. Frank is going to tell you more about how to do it, and I'm going to tell you sort of the data behind it. Next slide, please. So just very briefly, a question I often get is, why do children get COVID-19 infrequently with less severe disease? And there's a good study that came out actually early on in the pandemic that it helps to understand or explain this, which is that Ace2 receptors, these are these things on the cells called Ace2 receptors. They are the entryway for COVID-19 or SARS-CoV-2, the virus that causes COVID-19. They are how the virus gets into our body and leads to the infection. And it turns out that the ability to make Ace2 receptors, these doorways, varies with age, with elementary school aged kids making less of the ACE2 receptors compared to middle and high school students who make less ACE2 receptors than adults. So the implications are, if you have fewer doorways, less likely to have disease, and actually also more mild disease. Next slide, please. The other thing we know is that transmission among or from students is uncommon. And that's illustrated by one tiny case and also one really huge study. And the tiny case is just a sort of illustrative story that sticks in the brain. There was a French 9-year-old boy early in the pandemic. He had co-occurring, meaning at the same time he had both influenza and COVID-19. He went to 3 different schools. He had 80 different contacts, and there were 0 cases of COVID-19. But there were influenza cases. So that teaches us, like, oh, our normal mental model is that kids pass things around. It's just not happening with COVID-19 in that way. And the next study from Australia, huge study, 10 early childhood centers, 15 schools, over 6,000 people, showed overall very low numbers actually of COVID-19 and of people getting COVID-19 in those centers. And that's similar to actually more recent data from New York, because generally speaking, schools actually are a very safe and stable environment. Those who did get it, 90% of them got it from a household contact. So it's usually adult in a household give it to a kid. Transmission in the schools groups, you can see child to child, very infrequent, 0.3%. Child to staff, 1%, staff to child, 1.5%, staff to staff was 4.4%. That's 4 times more than the child to staff. And that's just because adults pass this virus around much more easily than children do, which is, again, gets to this point of we actually have control over our actions as adults. And so we can protect ourselves from passing them around from adults to adults. Next slide. So why don't children transmit as efficiently? You know, we just said they're not going to get it as often, but why don't they give it as often? And there's just some practical considerations. We don't have great science behind it, but we sort of know intuitively. There's a couple things to point out. One, they have smaller lungs. So that means when they cough, they make smaller clouds of viral particles. There's just less virus in the air to pass along. They have less severe disease, which means they don't cough as much, which means they just don't put out as much virus again. And then children are shorter than adults. So to the extent that COVID-19 passes by something called respiratory droplets, which Dr. Frank will tell you more about in a bit, there's both heavy and light ones, and some of them, the heavy ones go down. And if you're a kid, they go down and they don't go up to the adult. So they're just less likely to transmit. Next slide. Early on the pandemic, and even July and September, this was a story that sort of started to spread. And I think it's really helpful for people to understand that people said, aren't children super spreaders? There were some studies that came out, people got worried, maybe they're equally infectious or more infectious than adults. So I just like to talk about these studies briefly to explain them and help put them into the context of how we make a school safe. So one of the studies looked at kids with mild or moderate symptoms. They found that there were higher viral loads in children under 5 compared to ages 5 to 17 and 18 to 65, but they only tested symptomatic children. And it was early in the pandemic when we were really not testing kids almost at all. So those kids probably were pretty sick. And so it's not totally surprising that they might have had higher viral loads. The second study is out of India, 85,000 cases, 575,000 people were traced in the home environment. And they found that children were more likely to infect other children their age. If you were a kid and you passed it on to somebody, tend to be somebody your age, oftentimes because they were your siblings at home. And adults aged 20 to 44, though, were still the most likely to infect others. So what do we learn from this? There's a couple limitations, one of which is that we're just talking about viral loads in the first one. And the second one is the risk of transmission. We didn't really understand exactly what's going on there. People talk about, maybe it's the interactions with kids in homes, no masks, et cetera. And the other really helpful take-home point is that they only studied in both studies children who were symptomatic. So that means that this recommendation of do symptom screening, ask people to stay home when they're sick, whether you're an adult or a kid, stay home when you're sick, and that will cut this risk of transmission that we found in some of these studies. Next slide. So where are children getting COVID-19? This is a really nicely done study that actually was out of the CDC, the National Center for Disease Control group, and they looked at a group of students or children who had tests for COVID-19, and some of them were positive and some of them were negative, and they asked a whole bunch of questions. What were you doing? What kind of behaviors were you doing? So compared to the children who tested negative for the virus, the children who tested positive were more likely to have attended gatherings like weddings, parties, play dates, or funerals, but were not more likely to have attended childcare or school in person. So there was an equal number of kids who had attended childcare or school in person in both groups. It didn't increase their chance of having a positive test. Next slide. Another important study came out of North Carolina, and this is helpful because it talks about transmission in schools when there's high community prevalence, large numbers of cases outside of the school. It was a study from September to November in 2021, and they had community rates up to 29 cases per 100,000 per day. That's higher even than you're allowed to open an elementary school in California under California rules. If you are in the purple, you're higher than 10, and if you're in red, you're less than 10. So that's pretty high. They had a group of schools called the ABC schools. They focused on the 3 W's: wear your mask, wait 6 feet, wash your hands. They had 773 community cases, meaning cases in schools, that positive cases of COVID, but they only had 32 cases of in-school transmission, very, very low in those schools. And it was partly associated with very specific things that we can learn from. 3 clusters in the ABC schools. One was due to no masking in a pre-kindergarten, which is now a recommendation and that they changed in response to that. And then 2 in a special needs setting, 1 with eating in close proximity. So again, things that we know, actionable lessons that we can change and not repeat those mistakes. And they found there were no child to adult transmission cases. Next slide. They also found that North Carolina residents with COVID-19 during that time period infected approximately 1 other individual. So if the same number of transmissions occurred in schools, there would have been 800 to 900 cases in the schools, and there were only 32. So they talk about a couple other reasons for success: detailed plans, public reporting, and very importantly, the ability to share lessons learned peer-to-peer, which is part of what this group is also doing, is helping people learn, bringing people together, doing collaborative work. So the implications from the study are that mitigation strategies can make a difference, and they're key to our prevention, especially with our high community rates, and that data suggests that schools are actually safer than the community with those mitigations in place. And I like to give a lot of credit to, as Ms. Trotter was pointing out, routine, stability, peer groups doing the same thing together really allows for this, for safety to happen in schools. Next slide. This is a study also demonstrating limited transmission with masking, stable groups, and physical distancing. It's K through 12 schools in rural Wisconsin, and they had mandated masks. They had groups of 11 to 20 students, and the staff maintained 6 feet of distance, but the students actually did less. They did closer to 3 most of the time. And they had very little in-school transmission. They had 7 of almost 5,000 students had an infection during those 13 weeks, and 0 of the 600 staff. So no spread was known to have occurred in the staff or school, despite sometimes with very high community spread in that way. Next slide. Really helpful to highlight what we understand about high schools being different from elementary schools. This is from two studies coming out of France in the same region of France early in the pandemic. No precautions at all, no masks, no stable groups, no nothing, no ventilation. Community prevalence at the time was 9%, and they figured that out actually by testing everybody's blood to see did they have any sign of having had COVID in the past. That's called an antibody test. In the high school, they found that there were 43% of teachers and 38% of students had been infected, had some sign of having been infected. In elementary schools, 7% of teachers and 9% of students were infected. And the implications is that transmission can occur in high schools, but the community prevalence tended to be reflected in the elementary school cases. Next slide. And this is just a visual representation and sort of a modeling of what the elementary and secondary schools is the middle school and high school, sort of why it helps to explain. The two explanations, one is that Ace2 receptor story, the doorway into the body that we talked about in the very beginning. And then the other one is this, it's the structural piece, which many of you guys know. The elementary schools tend to be very naturally in stable groups, and those secondary schools, lots of mixing. So if there's an infection, it's easy for it to get passed around between the students and the staff, actually, because staff also tend to move around their classes a lot. Next slide, please. So the other question that many people ask is, there's all these things. It's a long list. There's masking, there's physical distancing, there's ventilation, there's hand hygiene, testing. Do we have any sense of what's going to be more effective? And so this is a study that came out of Berkeley, actually, UC Berkeley. They did a modeling study where they surveyed a bunch of people actually early on in the pandemic to talk about what their interactions were before the pandemic between work and school. And then they modeled what it would look like if people went back to school in the fall. And they looked at the effects of 3 different types of interventions: testing up here on the top, masking, stable groups, and then combinations of things. And you can see across the bottom the proportion of each group experiencing symptomatic illness over the fall semester, which of course we want to prevent that symptomatic illness. So you can see in teachers and students and household members. And I know that there's concern both for the students as OUSD goes back, and also concern from the staff on behalf of household members, and also the families themselves, saying, is it safe? Is it okay for our kids to go back even in high community rates, which luckily they're coming down, but as people think about what are their risks as they come back to school. And you can see, hopefully, I'm not sure how well these slides are going to come out for folks, but you have high school in the light blue, middle school, and elementary school. This is with no additional precautions. There's a pretty high proportion of people having symptomatic illness. This is monthly testing of teachers, monthly testing of teachers and students, weekly testing of teachers and students. It moves things along pretty nicely, but this is masking alone actually is more effective than the testing by itself. And then stable groups, and then you combine them all together, it looks really, really good. And you can see the same thing for the students and the same thing for the household members over here, that you can really bring down, even with masking alone, can really bring down risks to families because those safety mitigation layers are so important. Next slide. So this is just our summary slide. We know more than we did in March, and Dr. Frank's gonna go into greater detail here. Masking, physical distancing, stay home when you're sick, ventilation, symptomatic, asymptomatic testing, and small stable groups. I'm just gonna highlight one thing, which is that symptomatic and asymptomatic testing, the asymptomatic testing is this, ongoing, a group of people, teachers, students get tested periodically, because we know sometimes COVID-19 is asymptomatic, it's not showing up. And so it's another one of the layers that people use. And OUSD is already participating in 2 types of testing. One is called a PCR test, and the other one is an antigen test. And sponsored actually by the Public Health Institute for the antigen test to really support. The antigen test gives you results very quickly. And so it can create a lot of sense of confidence and create a really nice additional layer of safety. And so just I want to share with you guys that those are capacities within OUSD that the district is working to support, and they're partnering with the state. So the state lab has both those PCR tests and the antigen tests. Next slide. And just to summarize, I think this reflects Ms. Trotter's ideas also, which is if you want to go quickly, go alone. And if you want to go far, go together. And we got to do it together. That's the only way we're going to get through the pandemic. Thanks so much.
Thank you so much, Dr. Bardach. I learn so much from you every time you speak. There's some really wonderful questions in the chat that I'd like to ask you about, and then we'll hear from Dr. Gandhi. One question in the chat is, what data do we have about middle school?
Very good question. I have since like June been looking for good data from middle schools, and we don't have great data. A lot of the studies that they do, they clump 10 to 17 together, and so we just don't have it pulled out 100%. One of the theories people have is that the Ace2 receptor story is partly driven by going through puberty, which, you know, that sounds actually relatively plausible. So we know that there's a mixture of kids in the middle school setting. Some have gone through puberty, some haven't. That being said, the data we have about those safety mitigation layers include K through 12. And there's nothing calling out that middle schoolers are behaving any differently in terms of their transmission. And so those layers continue to be important: masking, physical distancing, et cetera.
Thank you. Another question that came up in the chat, in the Q&A, is, are there studies showing low school transmission from areas of the country more like the diverse populations that we have here in Oakland?
Yeah, great question. The data that is most publicly available is the New York City data, and they have, I haven't seen great, no, that's not true. Actually, there was a paper that came out in Pediatrics just a couple weeks ago that was specifically about New York, and they have very low case rates overall. And I don't have the data right off the top of my head, but I'm pretty sure they looked at in-school transmission as well, also very low. They did 6 feet of physical distancing at the time and had also masking and other mitigation layers in place. They did not have an emphasis on ventilation, nor did North Carolina, which I know is also a concern for all of us, you know, thinking about urban environments. So that to me is in some ways reassuring. I advise everybody, and Dr. Frank will say the same thing: optimize ventilation as much as you can, but all of these layers work together. So if there's one layer that's less perfect than another, the other layers really help to reinforce and to stop that transmission. And that's kind of the experience we're seeing across the country.
Great. And one final question from the Q&A right now, and then we'll have an opportunity for more Q&A at the end of the full presentation. Is the data that you showed us, or really sort of any of the studies, has it been tested on mutated strains of the virus?
So the experience we have, or the data we have about the variant, which generally speaking, people, when they say the mutant variants are thinking about, there's a variant that came out of the UK that is more contagious than the sort of initial variant, or the initial SARS-CoV-2, the virus that causes COVID-19. It shows that it's more transmissible. That variant is more transmissible than the original one, but it actually is similar across all age groups in terms of transmissibility, and that it also is it's susceptible to the vaccine, which is great, and that those mitigation layers are still going to be effective. So we still have to do those mitigation layers, and potentially we need to do them even more. People talk about doing double masking. So that's kind of what we know about the variant itself. It hasn't been tested per se. We don't have a whole lot of data about what it looks like in schools. There's some data from Israel, but it's not a perfect corollary. They got the variant, the UK variant anyway, sooner than we did over here. And the other data to let you guys know is that we actually don't have very much of the UK variant in California. We have a couple California variants that seem to be maybe a little bit more infectious, but potentially not actually. And the UK variant hasn't really spread very much here. And I'm watching the data very, very carefully.
Thank you,